Hello, everyone. Good day. My name is Mike Hamilton, and I'm Medical Director at ISMP Canada. Welcome to today's episode of the Med Safety Exchange, recognizing World Patient Safety Day, which happened yesterday. We thank you, of course, for joining us. We know it's very busy out there, and we really appreciate you took the time to visit us today and hopefully learn a lot about Med Safety Exchange and about World Patient Safety Day. We certainly appreciate you having you in the audience. Now we'll begin as we always do with the land acknowledgement. We acknowledge that we are hosted on the lands of the Mississaugas, of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. We are grateful to live, work, and play on this land, and we do want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. And as I say this, I encourage you to reflect upon where you work and reside. The webinar is a production of ISMP Canada and CMERPS with contributions from all our partners in medication safety and you, the audience. The Med Safety Exchange is presented, as always, on the Zoom webinar platform. Audience members are automatically muted and your video is disabled. And the presentation part of this webinar is being recorded and will be available on our website in a few weeks or so. There are a few ways to make comments or to submit questions. Find the Zoom toolbar, which is typically at the bottom or top of your screen. Use the chat panel to introduce yourself. Tell us where you're from. You can also make comments and ask questions via the chat panel. All chat entries will be visible to the audience. If you select the Q&A tool, the window will open up. You have the option to submit anonymously by checking off the lower box. Responses will not appear until they are answered. And please also feel free to email us at medsafetyexchange@ismpcanada.ca for any questions we don't get to. And there'll be an evaluation poll at the end of the session, and we encourage you to provide feedback. We have a terrific webinar planned today centered around World Patient Safety Day. I'll spend the first few minutes going over the themes and how it relates to medication safety. We'll hear a very important and compelling patient story to help frame the work we do and the importance of what we talk about. And we'll learn about the prescribing cascade, a concept I think we understand exists, but maybe we haven't had the opportunity to put that concept into words or really fully acknowledge some of the issues and all of the work that's going on in this field. And we'll have a presentation on the best possible medication history and how it relates to diagnosis, and how hopefully we'll understand how the BPMH is foundational to organizing medication therapy and benefiting the patient. And then my job at the end will bringing everything together and to speak about medication error or medication effect as a diagnosis. And then, time permitting, we can field a few questions from the audience in shared learning and discussion. Now, World Patient Safety Day is an opportunity to raise public awareness and foster collaboration between patients, health workers, policymakers, healthcare leaders. And this year, the theme from the WHO is improving diagnosis for patient safety. And the slogan is "Get it right, make it safe." And this highlights the critical importance of correct and timely diagnosis in ensuring patient safety and improving health outcomes. A diagnosis really identifies a patient's health problem, and that's really the key to accessing the care, treatment that they need. And a diagnostic error is the failure to establish a correct and timely explanation of a patient's health symptoms, including delayed, incorrect, misdiagnosis, or even failure to communicate that explanation to the patient. Diagnostic safety can be improved by addressing both systems-based factors and cognitive factors. System factors are organizational vulnerabilities such as communication failures, heavy workloads, ineffective teamwork, Cognitive factors include clinician training, experience, as well as biases, fatigue, and stress. And like medication safety, diagnostic safety involves multifaceted, layered approaches to strengthen systems. The support of healthcare workers in making correct diagnoses and the engagement of patients throughout the entire process. The goals of World Patient Safety Day this year are to raise global awareness of errors in diagnosis, give prominence to diagnostic safety and patient safety policy and practice, collaborate along policymakers, healthcare leaders, healthcare workers, patient organizations, and other stakeholders, and importantly, to empower patients and families to actively engage in their diagnostic process. And we'll see how during this hour, how diagnosis affects medication safety and how medication safety impacts diagnosis. Diagnostic errors account for about 16% of preventable patient harm, and they're common in all care settings. And they worsen patient outcomes. They can lead to prolonged or severe illness, disability, or death. They increase costs, decrease the level of trust in the healthcare system, and have psychological, social, and financial harm to patients and families. The diagnostic process involves steps, including the patient's initial presentation, history taking, examination, diagnostic testing, communication of these results, collaboration and coordination on a treatment plan, and ultimately a final diagnosis, follow-up, and reevaluation. And certainly errors can occur at any stage. Approaches to reducing diagnostic errors include a positive workplace environment, safety culture, quality diagnostic tools and processes, healthcare workers who are encouraged to continuously develop their skills and address bias and judgment, and patients who are actively engaged throughout the entire process. Correct and timely diagnosis requires collaboration among everyone involved, amongst all stakeholders, with patients, families, and caregivers at the center. And we'd like to thank the WHO for their tireless efforts in promoting safe care and for the use of the materials and slides today. We'd also like to let you know that WHO resources and slides are available to anybody from their website, the link presented. We do set aside only one day a year to recognize World Patient Safety Day, but we all sort of strive for safe care every other day too. So feel free to look at and use the campaign materials in your own organization. Now, there's no better way to center what we'll talk about, nor a more effective way to illustrate the issues in a patient's story. I want to reiterate that it's a very special type of generosity that patients and caregivers have when they share their sometimes very raw and painful stories. And we're really grateful for what they do in the hope of making things better and safer. I now invite our presenter to share a patient's story.
Thanks, Mike. Good afternoon and good morning, everyone. My name is Melissa Sheldrick, and I am the Patient and Family Advisor here at ISMP Canada. And I really am quite privileged to bring this story to you. And on behalf of the family, I would like to introduce you to Elizabeth and tell you her story about how medication issues were detected, but not acted upon despite her family actively advocating. Elizabeth's health deteriorated as a result. Elizabeth, a 77-year-old woman, spent her working years as a social worker in child protection. She was an athlete and remained active despite a diagnosis of idiopathic pulmonary fibrosis. Although she requires oxygen support, she's able to manage her daily tasks and has no cognitive decline. Elizabeth went on a new medication for her lung disease in the fall of 2023. It caused insomnia and major anxiety and unsteadiness. Her family doctor prescribed her lorazepam 0.5 milligrams in the morning and evening. After about a month of taking it as prescribed, her family noticed she was becoming curt and she was not sleeping well. She looked unhealthy. She was gaunt and had dark circles under her eyes, and generally she looked exhausted. On Christmas Day last year, she took 1.5 milligrams because she was so exhausted, and then she began to hallucinate. She panicked and became paranoid, accusing people of very strange things, and began to think that her friends were dead. She ran out of the house and drove herself to the emergency department. This behavior was very out of character for Elizabeth, as she always had a calm presence. By the time her daughter arrived at the emergency department, she looked like she was dying, and she wasn't herself, cognitively speaking. They investigated her for everything, specifically wondering about encephalitis and other severe conditions. Everything kept coming back normal. During that time, they were giving her lorazepam, and although her daughter suggested that it was the lorazepam that was causing these problems, they did not discontinue it. She began to display other symptoms, such as flapping her arms and legs, and her speech was unclear. Elizabeth was soon admitted to neurology. She had the psychiatry and neurology teams following her, and during that time, her daughter repeatedly asked them to remove the lorazepam. She didn't sleep for 8 days. She thought she was sailing the high seas, and she couldn't put a sentence together. She was having hallucinations and could hear every single sound. She would answer questions that someone was asking down the hall that nobody else could hear well enough because it was so far away. The care team thought she needed more lorazepam, as she may be going through withdrawal, and said they would first bump up the dose and then slowly taper it down. The family agreed because although they thought differently, they felt they had to trust them as they were the professionals. But nothing was working, and she was getting worse. Her daughter finally begged them 4 weeks later to stop the lorazepam completely. They listened. And a day and a half later, Elizabeth phoned her daughter and said, "Hi, sweetheart." The cadence in her voice was back. She was alert and recognized her daughter. She could concentrate and make sentences. She wasn't back to her baseline, but she was considerably better. She was smiling, and the family could not believe it. From there, the family saw improvement. The ferocious delirium was gone. Some days she was clear, but she still had a lot of confusion and sleepless nights that made her even more confused in the mornings. There were a few days where she had been completely clear. Geriatrics then began following her and made changes to her medication, which helped. She was referred to long-term care, but the family knew she was able to come home with a lot of support. At times, because she was directable, they told her daughter that her behavior was somewhat put on. This made the family angry. This is the kindest, softest woman who spent her whole life protecting children who were suffering from the worst abuse. She was selfless, and this behavior was not put on or exaggerated. The family knows that her care team truly did care about her and wants the best for her. In fact, she's seen some of them out and about since, and they hug her and they love on her. But the issue came down to the fact that they couldn't see the small changes, the change in her voice, change in her gaze, the tension in her shoulders. They couldn't see any of that, and that was the most important part because these changes were all caused by the medication taking effect. It's something only a close family member would recognize, and they didn't listen to somebody who knows her so very well. Healthcare is a team sport. When healthcare providers and patients and caregivers work together, not only is it for the benefit of the person, but it has so many other implications as well, including maximizing resource efficiency. This is especially important when trying to attain an accurate diagnosis. The picture is not complete without accurate historical and current information. Prior to the lorazepam removal, the family witnessed changes that the care team did not, as they did not spend a lot of time with Elizabeth. The family, who knows her best, was not being listened to despite repeated requests. Caregivers and family members spend a great deal of time with loved ones and know them better than anyone. It is imperative that they are part of the decision-making team during diagnosis and all the way through a health journey. Since then, unfortunately, Elizabeth had to return to hospital. The family is grateful for the care she's receiving, and the staff have begun to consult her daughter and family about all decisions in her medications and care. Elizabeth's care team is now closely collaborating with her daughter and family. Thankfully, she has been discharged from the hospital and is now home. Thank you all for listening, and really our deepest gratitude to the family for sharing their story with us and allowing us to share their story with you. Back to you, Mike.
Thank you so much, Melissa. And as you've said, thank you very much to the family for sharing. It's a very compelling, it's a very important story. And I really invite the audience today to keep Elizabeth in mind when we hear subsequent speakers. I'm a physician. I'm a prescriber. I've undoubtedly prescribed a second, even a third medication to deal with side effects or adverse effects of a previously prescribed medication. And it's really my great pleasure to welcome the next speaker, who has been a great friend to ISMP Canada, to tell us of the Prescribing Cascade.
Awesome. Hi, everyone. Thanks, Mike, for the opportunity to be here today. My name is Lisa McCarthy, and I work with the University of Toronto and Trillium Health Partners in Peel Region. And I'm really excited to be here today to tell you more about why prescribing cascades fit this year's World Patient Safety theme of improving diagnosis for patient safety. Now, like many of the presenters on this call, my passion for medication safety stems right from my very core as a pharmacist, a scientist, and also as a family caregiver who also went unheard while someone I loved experienced significant medication harm. So ISMP Canada's goal of achieving zero preventable harm from medication really does align with everything that I care about. Now, some of you may know me as a co-director of Prescribing.org. And there, what we do is we develop evidence-based resources to help people make decisions about when or how to reduce or stop medication safely. Today, though, I'm really excited because I get to help raise awareness about prescribing cascades, which is another topic that's near and dear to me. Next slide, please. So on the next slide is a summary of my disclosures. Being external to ISMP Canada, I do need to show you this. None of these, though, represent a conflict for today's session. And as we know, the world works in teams, and I've mentioned Prescribing.org, but I also want to acknowledge my partnership with Women's Age Lab in Toronto and the iCascade International team in this research. Next slide. So today, what I'm going to do is address 4 key questions at a high level. So first is, what is a cascade? Second, why do they matter? Third, how and why do prescribing cascades occur and persist? And lastly, what can we do about them? Okay, so let's dive in on the next slide. What is a prescribing cascade, and what are some examples? Okay, prescribing cascades are something that we see in practice every day, even if we don't recognize them. They start when an adverse reaction occurs and a second drug is prescribed to manage it. Now, this often happens because the new symptom or medical condition is not recognized as related to that first medicine. People then receive a new diagnosis and then typically more medications or interventions to manage that condition. And that's why we're talking about considering cascades as an important part of diagnostic safety. Now, sometimes cascades are intentional, like when we give a proton pump inhibitor for gastroprotection for a high-risk patient that's using a short-term course of an NSAID. Other times, though, cascades are prescribed unintentionally when an adverse event is unrecognized as attributable to someone's existing medications. Now, one of the really good examples is one that you may know now, actually, when a calcium channel blocker leads to edema that can result in a diuretic prescription. Now, that one always stands out to me because it's an always problematic or inappropriate cascade. Why? We actually have a mechanistic mismatch on that one. So calcium channel blocker related edema stems from fluid redistribution, not fluid overload, which is what diuretics address. So you can end up with a situation where people with normal volume status are at risk of dehydration. Next slide. So now you might be asking, let's dive a little bit deeper, right? Why does this happen? Well, people don't recognize side effects, and a key contributor of that is time. So first, think about a classic example where someone develops a skin reaction within hours or days of starting a new medication. In this case, the reaction is often linked to the drug by patients and the prescriber. Next slide. But there are other adverse events that take time to develop. And one example is pictured on this slide, where levodopa is prescribed to treat Parkinsonism induced by metoclopramide. Another example is one I've seen a few times in my own practice, where we've observed older adults with diabetes who were using loperamide for diarrhea. Nothing really had changed in their medication history, and many had been on metformin for many years. But on their blood work, there was a gradual decline in their renal function. And when we reduced doses or stopped metformin, that diarrhea resolved. Next slide. We're going to show you now another table with even more examples, and I know that you'd be able to generate many, many more of them if I asked you to do so in the chat. When I speak about this topic, the audience often varies. Most people, well, some people can list all of these, but typically there's at least one thing that catches someone's attention as interesting. Now, from a really quick look at this list, I want you to notice 3 things. One is that cascades can occur with a particular drug or a drug class. And here I'm using a really broad definition of the word drug. So prescription, over-the-counter, natural health products, other substances, it's all in there. Second, some of the signs or symptoms in that second column are very common. And so medication may actually only be one item on a very long list of differentials when we're talking about diagnoses. And third, think about how easy it would be for someone to experience more than one cascade or to be experiencing a sign or symptom that could be caused by more than one of their medications. Now I've taken a suddenly kind of simple concept and made it more complex, right? Next slide. Speaking of complexity, here's another example in the real world from a colleague who put together a pathway that their patient had experienced. And if you've done this detective work, you appreciate how much hours this can be in terms of pulling this history together. And you can see here that a cascade can really evolve into kind of a prescribing web. I also want to take a second to think about the impact of cascades for someone like this, a real person in the real world. Okay, next slide. Let's turn to the impact of cascades at a population level. So based on several studies, we know that there are many, many cascades, and data mining studies say that there may even be more than 300 targets. Reviews of published literature typically put the number at somewhere between 150 and 200, depending on the paper. Now, there are also several studies that explore their prevalence at a population level, or how often they occur. And this slide just has a few examples from studies that we've done at Women's Age Lab in Toronto. Overall, the absolute number of people experiencing cascades might be small compared to comparator groups, but small differences across hundreds of cascades can actually lead to an important number of people that are impacted by them. Next slide. In terms of how this translates into harms, remember that CCB edema diuretic cascade that I mentioned earlier? Well, that one's been really well studied and has been associated with an increased risk of emergency department visits as well as hospital admissions. We've also seen declines in physical functioning, which has important impacts for quality of life. And by virtue of adding more medications to a person's list through cascades, they contribute to polypharmacy that has all of its own consequences. And not listed on the slide is the environmental impact of using potentially unnecessary medications on our planet. So why do cascades matter? Let's recap 3 reasons. First, they're everywhere. We see them in practice, and once you start thinking about them, you'll not be able to stop seeing them. Second, they contribute to medication harm, both specifically and through their contribution to polypharmacy. And third, we can prevent and maybe deprescribe them if we recognize them. So I'm hoping I'll have time to come to some tools that talk about that. Next slide. So I'm going to say a little bit about why cascades happen and last. We've conducted 2 sets of qualitative interviews to explore this. In total, there were 51 interviews, about 18 patient cases from 3 different care settings. And all of these cases involved people 65 and older who may have experienced at least one cascade. In both studies after the interview, we asked the patient for permission to interview anyone else in their circle of care who might be able to speak to their cascade experience. And we learned a lot from these studies in terms of how complex cascades can be, how people struggle to identify and manage them, as well as varying levels of willingness to be accountable for prescribing decisions that are made by others. So let's go on next slide and go a little bit deeper. What do I mean? Okay, well, first, people's ability to recognize cascades was linked to their awareness of medication side effects. Makes sense. Simply stated, we found that overall, the patient's knowledge of medication side effects was typically low. Physicians were not much better, which they largely attributed to a disease-focused approach to symptom management in their training. Pharmacist knowledge was higher, but not as high as you might expect. Like physicians, they relied on patients to report new symptoms, and the likelihood of investigating symptoms as potentially medication-related decreased over time. Second, across both studies, often potential cascades couldn't be confirmed due to a lack of information regarding why a medication was used or the timing of prescribing. And third, people's willingness to consider and act on cascades was impacted by varying levels of accountability for medication decisions. Health professionals were accountable when they made, the prescribing, but were really reluctant to make decisions about medications for which they were not the original prescriber, and particularly when they didn't have all of the information for the history or if a patient was resistant to change. For patients, their interest in being involved in their care varied from none to a firm believer, and rightfully so that they were a partner in care. Next slide. Now, clinicians also told us about the detective work that was needed to gather a medication history and to sort out whether a cascade happened. Alice will talk more about this. All of this was made harder by lost history during care transitions and patients' inability to recall why medications were prescribed or when. Some clinicians talked about uncertainty and how that led to a reluctance to act, particularly if someone seemed stable. Interestingly, some clinicians talked about managing or acting despite uncertainty by using a deprescribing trial to test their hypothesis that a cascade had occurred. This usually involved reducing the dose or pausing the original medication that could be causing the adverse reaction and then monitoring to see whether it resolved. Next slide, please. What can you take from this in terms of what you can do about cascades? Okay, first, knowledge gaps about why a patient's prescribed a medication, the timing, and more globally, the side effects of medications impact everyone, patients and clinicians. These gaps interfere with our efforts to monitor medications globally and to confirm cascades. So as a call to action, I want you to imagine a world where patients, caregivers, and health professionals documented and shared with one another the reasons for medications, when they were started, and their intended effects. Second, we need people to question, could this sign, symptom, or even new medical condition be caused by a drug? This is really key, especially when someone's clinical status is changing. Use a broad lens and think about this, regardless of the time that's passed since the drug was started. This applies to health professionals and the public too. Clinicians might be more inclined to act if patients asked about how their medications link to new symptoms. However, these two actions alone aren't going to solve the problem, because even when people consider drug causes, they're not able to easily access information often to confirm potential cascades or develop plans to manage them. And so that leads to my third call to action. Strategies to investigate and manage prescribing cascades include deprescribing. So rather than investing a ton of resources and getting stuck when a history is not available to confirm a cascade, a trial of deprescribing can help. Okay, next slide. Almost done my part before we finish today. I want to give you a few tools to help recognize cascades and to support your deprescribing efforts. On this slide is something called Think Cascades that I led development of. And this is a short list of 9 cascades that were selected by an international panel of experts to be key clinically important prescribing cascades impacting older adults. It's interesting, I know Elizabeth's story is actually featured on this list. Since its release, we've been excited to see the interest. We've also had feedback about whether or not this list resonates for them in their particular context. And I welcome that debate, because having an internationally derived shortlist helps to give people a place to start, which was our intention. And by raising awareness and discussion about these cascades, we're actually raising awareness of the phenomenon more broadly. Once you start to see cascades, it's going to be hard to stop, I promise. Next slide. Now, I've talked about deprescribing.org a few times. If you haven't seen our site or our internationally known and adopted deprescribing guidelines and algorithms, check them out. They're all available on our website at no cost. We've created 5 guidelines ourselves, but have partnered on several others, including a newly released opioid deprescribing guideline. We are also actively working on tools for our soon-to-be-released statin guideline and are looking for pilot testers who practice in long-term care environments. If you're interested, reach out. And for completion, next slide. We also have frequently downloaded patient pamphlets, whiteboard videos, and an online learning module about polypharmacy and deprescribing that's great for learners. There's an app that's free for download on the Apple and Android platforms. And finally, you may already be joining us on social media, but if not, give us a follow. We have exciting things ahead. And thanks to ISMP for letting us share some of our resources today. So next slide, last one. In closing, in keeping with the slogan for World Patient Safety Day, which is get it right, make it safe, I'm going to offer you 3 takeaways about cascades. First, cascades occur when a medication is used to treat the side effect of another medication. These often happen as a diagnostic error when the side effect is misinterpreted as a new condition. Sometimes cascades make sense and are appropriate, but often they're not. Second, to help prevent and identify cascades, think, could this sign, symptom, or new medical condition be caused by a drug? And third, deprescribing is a strategy that can help investigate and manage cascades. So if I've made you excited about cascades or you have any ideas you want to discuss, my contact information is on this slide, and I look forward to your questions. Thanks.
Thank you very much, Lisa. It's really eye-opening to understand how frequently prescribing cascades can develop, and really appreciate your 3 calls to action and all the tools. And you're right, it's a pattern recognition, and it's, it is a type of pattern recognition you need to perform once you understand what the medications are. And I think a really useful tool for that is the best possible medication history. And we are going to ask Alice to tell us about it and how it can assist in diagnosis, in pattern recognition, and hopefully you'll begin to see these prescribing cascades everywhere. Alice?
Thank you very much, Mike, and hello, everyone. It's great to be here. I'm Alice Watt, and Senior Medication Safety Specialist at ISMP Canada, and I'm thrilled to be here today to celebrate World Patient Safety Day with you and to also talk about an important first step to improving the diagnosis. Now, when thinking about the diagnosis and what else it could be, just like Lisa's question, we have to ask, could it be the meds? Could it be the drugs? Elizabeth's story demonstrates just how important it is for the team and for the patients and for family members to ask this question. Now, to be able to review these medications, we first need to have a complete and accurate medication history, or what we like to call the BPMH, or best possible medication history. The BPMH is a snapshot of the patient's actual medication use. It involves a systematic process of interviewing the patient and their caregiver to obtain, verify, and document all of the patient's medications, regardless of whether it is prescribed or non-prescribed, including medications that you could buy without a prescription, like non-prescription medications, herbal medications, and even cannabis or lifestyle medications. I strongly support Lisa's excellent calls to action to document and share the reasons for use for each medication, because these are the diagnoses that the patient carries. This snapshot really gives an important picture of the number and the types or even the severity of the conditions. This can help dramatically when integrating this information you have collected about the patient through the medical history, exam, and investigations, and thinking about the diagnosis for the patient's issues. On the next slide, you'll see without a complete BPMH, it is like trying to put a puzzle together without having all the puzzle pieces. You just can't so easily solve this puzzle of what's happening with the patient and answer the question, could it be the medications, if you don't know all of the medications the patient is actually taking. The detective work can't happen without all the clues in front of you. On the other hand, a complete and accurate best possible medication history, as this diagram shows, can allow for medication reconciliation to occur, resolving any differences between the medications at transitions of care. And it can also lead to being able to perform a thorough clinical medication review and the deprescribing of inappropriate medications or prescribing cascades, as just shared by Lisa. On the next slide, another reason why BPMH helps with diagnosis is that incomplete medication histories that are inaccurate can be a source of medication errors, and these errors could cause harm, especially when patients move from home to hospital or goes from hospital to home or returns back to the long-term care home. I'll give you an example. In a recent Safe Med Use Bulletin, we received a report where a home care nurse was able to identify the reason why the patient who had just been discharged from hospital kept having recurrent falls at home. When the nurse did the best possible medication history, she discovered that a blood pressure medication that was stopped in hospital due to a patient having low blood pressure was inadvertently continued in the patient's blister pack at home, causing them to feel lightheaded and dizzy, which was contributing to their fall. Following a systematic process to create the BPMH and reconciling them in a reliable way can help reduce the risk of communication failures at these transitions. So on the next slide, I'd like to introduce to you our newly revised BPMH interview guide. It is a list of questions to equip healthcare providers and patients to prepare for a comprehensive medication history interview. So one aspect of this guide I'd like to highlight includes a key question to identify anything that makes taking medications difficult for a patient. For example, the affordability of medications or the cost, problems with swallowing, low vision or reading difficulties, not remembering to take the medications, or even difficulty opening the bottles. Asking these types of questions, and more importantly, listening to the answers from patients and care providers, can get to the heart of why some people are unable to take their medications regularly, which can also help explain the reason for the patient's presenting illness. In fact, a recent study by Dr. Mary Dam from Australia showed that how we communicate and listen to patients plays a crucial role in the diagnosis. The time we spend talking or taking the patient's history, which includes the medication history, and listening to the patient is time well spent. And it gives the team a better information to fine-tune their thinking about the diagnosis, which means they're more likely to get it right. So I hope you'll check out this tool in the link provided. So on the last slide, how could a BPMH help with the diagnosis and answer the question, could it be the meds? Well, knowing the complete list of medications could help you identify side effects causing harm. For example, I've seen many times where during my BPMH interview that the patient actually just started recently taking high doses of anti-inflammatories without stomach protecting drugs, and they come into the hospital with symptoms of coffee ground emesis and possibly GI bleed. Knowing that they started ibuprofen can help us understand why that happened. A BPMH can also identify overdose or toxicity. In a recent article from Dr. Nathan Stahl, a researcher and doctor from Sinai Health, in his research on the increasing numbers of edible cannabis poisonings in older adults, he noticed that some patients were sometimes being erroneously worked up for stroke because the patient did not know about the team did not know about the patient's use of edible cannabis causing this toxicity. Our BPMH guide has a new whole section on cannabis and lifestyle medications. It could also help with identifying drug withdrawal symptoms. Safe Med Use received a report from a consumer who was experiencing tremors, sweating, and other symptoms. And while talking with their community pharmacist during the medication review, the consumer shared that they had stopped taking their antidepressant medications a few days earlier without a defined plan to gradually reduce the dose. And the pharmacist was able to recognize that the consumer was experiencing withdrawal symptoms. It can also help identify drug-drug interactions. Sometimes a combination of medications can affect the heart's rhythm, causing QT prolongation. And only when we see the entire med list can we recognize the additive effects of the interactions. The BPMH information can also be used to help identify drug allergies. Sometimes a patient can develop an allergic reaction to the medication, and knowing about recently added medications on the BPMH list can help narrow down the culprit allergens. And lastly, it can help identify inappropriate medications that have no indication, or perhaps the patient is no longer in need of it. So I've done a lot of talking. Now here's your opportunity to contribute your experiences. I hope you'll take a moment to put in the chat, how has the BPMH helped you as a clinician or healthcare provider and your team make the right diagnosis? Maybe it's similar to some of the stories I've already shared. And if you're a patient, I'd like to ask, how do you keep your medication list up to date? That is such an important part of being empowered to know your medications. How do you do that? And I'd love to learn from you. Have any of you seen wrong doses that you found that cause side effects? Have you seen drugs that should have been stopped that caused problems for the patient, or drugs that were supposed to be stopped but should not have been? What proportion of medications that you cannot for the life of you identify an indication? And how many of you have found multiple anticoagulants causing bleeding? Let me see if there's any stories here about people that have shared. Okay, so I'm going to read one here. Let's see. Just want to see if anyone has shared any stories. Okay. I'm going to read Angela's story. Case in point from a professor I had in graduate school. A female patient was in hospital unable to void after a urinary catheter was removed. My professor spoke to the patient and found out that they were having trouble voiding prior to catheter insertion and it had been ongoing for a while. After a medication review, they identified 2 antidepressants, one which was amitriptyline, which is known to cause urinary retention, and stopping the amitriptyline resolved the urinary retention issue. Awesome. Thank you so much, Angela, for sharing. And as more of these stories come in, I'd love to learn more from you what kinds of stories you found in your practice, and also from patients, what kind of tips you have to keep your medication up to date. One thing that healthcare providers can do is after they do the BPMH, they can give a copy of the BPMH to the patient, and that will help them keep it up to date. So thank you for all your wonderful stories, and I look forward to reading them all, but I think I will hand it back to Mike to put it all together. Thank you.
Thanks very much, Alice, and thanks to the audience members who contributed their experience to the chat box. It's important that we see these and learn from these so that it recognizes, and we can help recognize prescribing cascades as well. So I want to spend the next few minutes talking about medication error as a diagnosis, and I think you've got a flavor of what that entails from the previous stories. We are sort of brought up in our various disciplines to think of medications as the treatment for symptoms, for diagnoses, for conditions. In a lot of cases, medications are the end result of our efforts. Diagnosis comes first of some pathological, physiological entity, and then we give them a medication to hope that it ameliorates the condition. But I hope that what you've heard today can make you consider that medications can, in fact, not merely be the intervention of a diagnosis, but they may also be the reason for symptoms or signs. They can actually be a part of, or even the whole of a diagnosis of a patient's presentation. In the next few slides, I'll go through a few examples where medication error was indeed the diagnosis, although you've heard a number of these today. So we have a community patient presenting with persistently high blood glucose levels, dizziness, fatigue. We know, looking through your chart, that they were prescribed metformin, 1,000 milligrams twice a day. Their vitals, their glucose might be a little high, BP might be a little low, respiratory rate's okay, heart rate's a little bit low, temperature is fine. So you investigate a little further and you identify that metoprolol, 100 milligrams twice a day, was dispensed in error rather than metformin, 1,000 milligrams twice a day. In this case, the key to identifying the problem was a review of medications in the context of how the patient was presenting. And in this case, the pharmacist accidentally mistook metoprolol for metformin. Maybe they were side by side on the shelf. Maybe they're from the same company with the same bottle. They looked very similar. And in this case, the medication error was the diagnosis. And in the second case, an orthopedic surgical procedure under a spinal anesthetic, a patient reported extreme pain and demonstrated unusual movements. These persisted into the recovery room where the patient also experienced seizures. Neither the anesthesiology team nor the surgical team identified the diagnosis at this time. But in this case, tragically, the wrong product was injected into the spinal area. Both products are in vials, tranexamic acid and local anesthetic, and both are typically present in the operating room, and both are often used during procedures. Again, in this case, there was an accidental switch in products that led to the signs and symptoms, although, albeit in this case, with more severe effects. So there are three important aspects of medication therapy. Firstly, that your clinical reasoning results in the proper diagnosis or a short list of potential diagnoses. And secondly, that the most important and effective therapy is chosen. And thirdly, that medication management processes are followed to ensure the selected therapy is safely administered to the resident or patient as intended. This is a chain of happenings, and you need the correct diagnosis to arrive at a correct treatment plan. The treatment plan needs to be carried out with a high degree of precision and accuracy and timeliness. And the response to the treatment plan needs to be fed back into the process to really evaluate whether or not you do have the correct diagnosis or the correct treatment plan. Ask yourself, is the patient responding as you might anticipate? Are the symptoms behaving? This all contributes, I think, to the nexus of diagnostic safety and medication safety. It's all built in together. And we need to recognize where diagnostic errors can occur. And because we're a medication safety organization, how medications play a part in diagnosis. They're a critical part of the history, as you've heard from Alice. That's why you do a BPMH. It equips you with the most up-to-date knowledge about what a patient is actually taking. Whether it's a new medication, old medication, whether it's an allergy, when it was started, it helps you to look for prescribing cascades, for interactions, for side effects. And think about medicines a patient's not taking. The diagnosis of a persistent rash might simply be you prescribed a cream that they can't afford, so the eczema goes untreated. And be aware too that medications can influence lab results. Drugs can mask test results and be the cause of abnormal test results. Respiratory inhalers can cause a normal pulmonary function test, so your asthma goes undiagnosed. Elevated INR can be a liver disease, or it can be simply that the patient's taking their husband's warfarin accidentally. Communication and discussion with the patient really helps sort all this out. A BPMH, as you've heard Alice said, is really important for this. And when you put all this together, you, the team, the patient, have arrived at a diagnosis, and you collaboratively decide on a treatment plan. Center the patient, discuss the risks, benefits, and requirements so that they know. Help update their BPMH, their medication list. And we're not done there. We need to still monitor and evaluate the plan to ensure that this is exactly what we want. This is the correct diagnosis. And there are things you can do to help your diagnostic approaches. Keep your skills up to date. Recognize your bias. Challenge your own thinking processes. Be an effective team player. Ask for help. Be open to receiving advice. Collaborate again with patients. Keep focused on the person at the center of the diagnostic process. And understand the diagnoses is a real team effort. There's patients, families, caregivers that can use tools such as the 5 questions to ask about medicines. Healthcare workers are important, providing clinical care. They need to make diagnostic excellence integral to their daily practice. You need healthcare facility leaders and managers to implement safer systems, better diagnostic pathways, quality diagnostic equipment. You need policy, practice, culture to promote continuous learning, practice improvement, diagnostic excellence. You need patient organizations and civil society to advocate for quality and safe diagnoses. And you need regulators, manufacturers, and innovators and managers to really innovate for smart solutions in diagnoses and really drive research and development for diagnostic tools and technology. And almost all adults will experience at least one diagnostic error in their lifetime. Some of these will be related to medications, but together we can get it right, make it safe. And this includes considering everything you've heard here today, that medication errors and medication effects can indeed be the diagnosis. So I want to thank all the presenters today for sharing. The chat box Q&A has been very, very active today, and thank you for all that in your comments. And thanks to the panelists for sharing their experience and expertise. And I think we have a couple of minutes for questions, so I'll invite the panelists to join us as we answer some of their questions. And if you do see a poll, please answer it. It helps us to get better. So I'll start maybe with Lisa McCarthy, question for you. Um, each specialist is sort of focused on their own conditions and medications. Do you think that this type of fragmentation of care, with patients having specialists for each condition, with patients having sort of a wide variety of over-the-counter and available sort of medicines, contributes to prescribing cascades?
I mean, how could you say no? 100%. The more people that are involved in someone's care, the more we see kind of fragmentation across a whole bunch of issues related and related to their medications. It is very easy if somebody isn't taking a holistic look at all the medicines and the timing of them to miss potential prescribing cascades. And that's certainly a piece when you have a lot of different players involved in your care, which is why I advocate for everybody to always ask, can this be my med, to everybody that they get in front of?
Yeah, that makes sense. It's a really, I think it's reliant on a lot of primary care practitioners, including community pharmacists, including family doctors, to sort of ensure that these lists are up to date, ensure that there's somebody with sort of a global overlook onto the patient. And this includes family members as well.
There was a comment in the chat about somebody raising, I thought that electronic medical records were going to help with this. And I think that the public in particular, may be shocked to realize how poorly connected a lot of our electronic medical records are, particularly with respect to medication information. It varies across the provinces in Canada, of course, but in Ontario context, where I am, and a lot of us are, the best advocate, the one that really knows the list, is the member of the patient or the public themselves. Alice, I think I'm singing your song. You can go ahead and take the tune here. Yeah.
Yeah, I 100% agree with you, Lisa. Like, you go to a bank and you think you're balanced. You go to the bank down the street in the same bank, they still have your balance. But if you go to the pharmacy down the street with the same name, they don't even have your record. So I think we do have a lot of work to do when it comes to getting the record talking to each other. I really liked Jeanette's comment. She said, just maybe a simple medication list given to the patient on a business-sized card, front and back. She said that might be a very useful thing, and I support that. I think as pharmacists, we can do a better job of helping patients have a handy way to keep their medication list and maybe help them out.
Yeah, I think one of the questions was, or one of the issues that people found with the BPMH is sort of immediately after you've completed, somebody goes and makes a whole bunch of changes, and it's really hard to keep that up to date, particularly if you're, a busy practitioner, or if you're, you go to 3 or 4 different specialists as a patient, and they all make their, certain changes. You've identified a couple of things that might help. Certainly if we had integrated systems that talk to one another, that would be great. But are there any other things that people can do to help keep the BPMH up to date?
Yeah, I think you've kind of I think there's real potential in technological solutions like apps and things that can keep track. But I think as working in a hospital, we really have to do a better job of telling the patient all the changes that I've made and be able to help them update whatever technology that they're using, because otherwise they have to maintain it. But the more that we can support them, especially after these transitions of care, a lot of changes in medications could happen. So I think it's important we could try to use the technological solutions maybe and get one record going. That'd be great.
Yeah, I think that would improve a lot of things in diagnostic safety and decrease in duplication, and certainly medication safety. There's no doubt. So I'd like to thank everybody for coming, particularly the presenters for their excellent stories, particularly the family for sharing what they went through and helping us to understand that this affects real people. We'd also like to thank you, the audience, for learning along with us on our World Patient Safety Day episode. Please let us know what you think by contacting us or completing the feedback poll. Importantly, we learn from you, we learn from others, we learn from these stories. We'd love you to share your story with us. we would love to share experiences in order to make care safer. So please be a part of this medication safety exchange by reaching out, by submitting ideas, by submitting some of your projects. Again, the link to this recording will be available on the Med Safety Exchange website in a few weeks, along with links to the websites and other materials. And a PDF of the slides is available upon request if you send your request to the Med Safety Exchange at icpcanada.ca email address. And having reached 1 o'clock, we invite you to come to the next session of Med Exchange, which will be held towards the end of January 2025. Again, thank you very much for participating, and have a terrific remainder of the day.